morning and welcome to our monthly live broadcast for peripheral endovascular cases from Mount Sinai Hospital here in New York City. I'm your moderator, Vishal Kapoor, and we welcome you for another exciting case here at Mount Sinai. As you all know, Mount Sinai, especially the interventional cardiology department and the endovascular department led by Dr. Krishnan and his teams, we've been at the forefront of newest technologies, growth in advancements, and in research, whether it be from drug-coated balloons to drug-coated stents, being a part of Life BTK and installing one of the first bioabsorbable scaffolds in the whole of North America, and now everybody and now being a part of the renal denervation system. So this is one of the latest technologies I'm sure everybody's heard of. Some of you have tried, had a hand onto it. And today we are proud and honored to be part with the Medtronic team here, which I'm going to introduce, to present a case of renal denervation. Just give you an idea of this latest technology, which is probably going to be one of the game changers for treating patients with essential hypertension, which form an essential part of our cardiology practice for most of us. So I'm here joined by our Medtronic team. Let me introduce her. We have on my left is Ms. Hydra Bowman, which she's the
Morning.
Senior Director for Medical Education at Medtronic. And to my right is Stefan Tunnel. He's the Senior Distinguished Scientist and one of the brains behind this technology. So welcome, guys.
Thank
Welcome
you.
to our monthly
Thank
live
you.
broadcast. So good morning, PK, and let's see what we have for the renal denervation for the whole world.
Introduce our team before we get started. To my right is Dr. Raman Sharma, who's been with us for many years and has always been a huge assistance in terms of doing these complex cases. To his right is our endovascular fellow, Shalini Mani, who's here from Chennai. It's the first time you guys are meeting her. Last time you met Dr. Harsh Doshi. So Shalini is a certified interventional cardiologist in Apollo Hospital in Chennai. We're proud to have her join us and really planning on learning endovascular intervention and intervention here and then taking it back home to help the people in India. To her right is Ray Lascano. Ray's our interventional endovascular nurse practitioner. And then our wonderful team here is we've got Elizabeth, who's been here, and we've got Damien, who's helping us. So before I start, I want to just to tell you guys it's a month away from NYEVS. I want all of you to get excited and join us there. Obviously, Dr. Sharma and Dr. Guja are leading the endovascular fellows course, which is very, very excited. We've already, for the fellows watching, we're pretty much sold out, but definitely will accommodate those who want to. And as you know, Dr. Sharma and Dr. Guja have a wonderful case competition already ready to go. So we're awaiting your wonderful cases to compete with great prizes. Interestingly, in NYEVS, we've actually partnered with multiple industry partners. And prior to NYEVS, we have the Innovations and Imaging Summit, in which Medtronic is going to hold a renal denervation summit, where they're going to have experts like our two guests today, as well as multiple physician leaders talking about renal denervation, the nuances, and we hope to kick it off with today's case. So again, not to belabor the point, but we're ready to go, and we're going to start with our case presentation. So Shalini, with a brief presentation before we get started.
Yeah, good morning, everyone. Our patient today, he's a 33-year-old gentleman who's been referred from the Index Primary Care Team for management of resistant hypertension. He's a known case of hypertension, type 2 diabetes, and which one?
You got to press the button, yeah.
Hyperlipidemia. He underwent a bariatric surgery in 2022. Post-bariatric surgery, he lost some weight, which essentially helped his diabetes management. However, his hypertension remained uncontrolled. Despite being on maximum guideline-directed antihypertensive therapy, he had multiple episodes of hypertensive crisis. His hypertensive medications were 100 mg Hydralazine, he's taking twice daily, and 25 mg of Carvedilol and 80 milligrams of Valsartan, and he's on an anti-lipid therapy, and he's been worked up for secondary hypertension. His renal arterial
We'll do it live.
duplex is normal. I couldn't go to
This
this.
one. This is the top one.
Yep. You passed.
Go back.
Uh,
Let's see.
the second slide.
There you go.
Mm-hmm.
That's the secondary
Before one.
workup.
One more slide. Yeah.
There you
Yeah,
go.
There
his
we
renal arterial duplex was normal, no renal artery stenosis.
And no evidence of FMD, very important.
Yeah, no evidence of FMD, and has metanephrines, aldosterone, renin, aldosterone ratio. Everything was normal except a mild elevation in renal parameters. Everything was normal.
So this is a gentleman, obviously, who is probably a classic indication for renal denervation, presented with multiple hypertensive emergencies and urgencies, multiple admissions, despite maximum medical therapy. He was on other medications that he has not tolerated. Obviously, not only three. He's tried on everything by one of our hypertension specialists within our system, and clearly we are hopeful that this particular device will help. But before we get to the presentation, I know we want to set the device up. I'm going to have Dr. Sharma and Ray walk through the setup of this device. Raman, Ray?
So, again, thanks for joining us today. Luckily, the setup is a pretty, pretty straightforward. There's a back plug which ends up going to the Medtronic Symplicity generator. The generator itself has a few separate components to it. One that include the insertion port for the catheter itself. There is a ground pad that also has to be put on the actual ground, and it's its own separate plug. So these three things, as long as you have the staff fully well educated on how exactly to be using and how to actually set up, you shouldn't really be having much of an issue for at least the setup portion. The grounding pad is very, very important, because without this, you won't really be able to generate the current you need to actually create the full denervation effect. And then again, on the monitor, it has all the basic stuff about how to insert the the patient information. As we get closer to actually doing the true denervation part, we'll talk about more about how to use the actual the handle and controller itself. We can, I guess, briefly talk about a little bit about the unloading.
To the AV team, can you focus on the generator on the other side? Is it possible? Can you rotate the camera to the generator? Because I want to show how intuitive it is.
Yeah.
Can you rotate to that camera? Hold on, we're going to just rotate a camera as Dr. Sharma talks.
Move this back.
Yeah, there, he's got it. There you go. There you go. Perfect. That's it. Yeah, you can show the generator. There you go.
Good.
Yeah, now we can see the generator, yes.
So this is a good start. So it says insert catheter. But is it fully plugged in?
It needs to be in the patient.
Into the body.
It needs to be in the patient.
Until we're fully inside the body, we're not going to be able to do more. The handle that's over here is really important.
Can you go on Dr. Sharma's hands?
We'll be able to show exactly which of the. See if we can turn. There we are. Yeah. So this handle we have here, you can't see too well because of the lights, but these four lights here, now you can see them a little bit better. Right. These four lights are basically going to be the four buttons are the ones that are going to be able to use to actually control each of the individual electrodes that are going to be on the Spyral catheter. There's a mode select whether you're working on the right or the left kidney, so the machine also knows, and then simply about how to deliver the actual pulse itself.
Let's go with the run.
This is going to be important because this is going to be how you will be able to select which of the actual electrodes will be doing the actual the delivery of the actual electricity or the radio frequency to do the actual denervation portion, because there are going to be times where you may be having overlapping of the actual electrodes based off the length of the segment of the renal artery that you're going to be treating, that you would actually not want to double treat in a particular area, or if you're at the level of a carina or a bifurcation, you want to limit the amount of energy being delivered over there. The machine itself is again does the bulk of the work. Assuming you have good contact, and again, we'll be able to talk a whole lot more about that, you should be able to deliver the total of the 60 seconds of the therapy. Sometimes what may happen is that you may have issues where you have inappropriate vessel contact, too much impedance, and so on and so forth. And when this happens, the machine will make it very, very clear to you, and it'll turn that catheter off. It'll turn either just that specific electrode off, and I'm sure we're going to run into that here. And it will say that this particular electrode was not able to deliver the full therapy. I believe they say at the minimum 45 seconds of the therapy has to be delivered for the therapy to be considered complete. 60 is obviously better than 45. At the end of the day, unfortunately, this is one that does take a little bit of time. And we'll talk more about, I guess, as we do the angiogram and we decide as far as how we're going to be sizing these, which vessels we'll be talking about to be treating, how we're going to make sure we don't miss any of the accessory vessels, the accessory renal arteries, how far into the actual kidney artery we're going to be going. So all these technical considerations we're going to be talking about in just a few moments here as we're getting set up. We have a initial picture here.
Let me just show you guys. So I think it's very important if you come to the angiogram to do a quick diagnostic angiogram. We obviously did Stefan, Hydron, Vishal, if you can see this. We did a shot. Obviously, he's got typical, pruning of the distal vessels, single large renal vessel bifurcating into two short stalks, and then multiple smaller branches going out to the distal. So the question, I guess, here, as maybe Stefan and Hydrum could talk about, is how far out you should be going, what are the size of the vessels, et cetera, et cetera. So this is the left renal artery. We did it with a diagnostic JR4 just to prior to, and then the right renal is right here. Again, here you have another early branch, which is a little bit larger than the other one. And again, I don't know how far we should go. We'll talk about it with everyone. There's no obvious renal artery stenosis and definitely no FMD in this particular vessel, but you can see it's a hypertensive patient with distal pruning of the vessels. Luckily, not a bifurcating or multiple branches here. All the renal poles are lit up, and I think that's important angiographically to make sure that you see all the renal parenchyma light up when you do an angiogram. We'd like to limit dye here in this gentleman, so we're not going to take many pictures. And so before we enter the body, I just want to ask Hydron and Stefan on some comments and some thoughts before we start, and then maybe we can talk about whether you want to start the procedure and then do this. The one thing I do want to talk about before we do anything is the no-touch technique. So very important for the cardiologists at home. Everybody wants to stick guides in kidneys. It's not the right thing to do. Everybody can have atherosclerotic renal artery disease or aortic disease, and after a certain age, even a young gentleman like this. So very important to obviously deflect the catheter away from the renal ostium when you go up with a guide. And you can see in this particular one, we have the woolly wire that's pushing the catheter away. We wire without touching the ostium, and then advance the supportive wire into the vessel. Right. So this is a little technique, and then we can get started. So just completely up to you, Vishal. Tell us whether you want us to go in, or maybe Hydron and Stefan want to make comments.
I'll just throw in, how for a practicing physician to see, how we get these patients, which ones become eligible for renal denervation and hypertension. That's always the question when you go out, whether it be for referring physicians or for one's own practice. So for Hydrum and Stefan, starting with you, Hydrum, for workup, like PK and the team showed up, the workup, do you have a standardized protocol? Do you look for anything else, or is this workup enough of having your renal Doppler, your metanephrines, your renin angiotensin, and that's it? Would that suffice with the compliance of the patient, or there's anything else needed in addition to what they did?
Yeah, so this is always a great question. And I think usually the patients that you are seeing, they are already in a hypertension career, and they have been through quite some workup to rule out secondary causes. So I think what you've seen here is actually sufficient. It's always good to exclude renal artery stenosis before you put the patient on the table. So it looks like that you did it with Doppler ultrasound. And then really make sure that, for example, when you also get home blood pressure measurements or 24-hour ABPM, also to get this information to really ensure that we are not dealing here with white coat hypertension. With this hypertension career, I just don't see a risk that this might be the case here.
Right. Okay. So for Stefan, for you, we have the angiographic analysis, the renal artery, like you said, no FMDs, no renal artery stenosis. We do an angiography, and let's say we missed an accessory. There's a very small accessory. Would that be the inhibitor for you to go ahead with renal denervation, or you're still okay with doing it? What stops then accessory vessels or being not a candidate for renal denervation?
Yeah. So typically we're wiring and treating vessels between 3 and 8 millimeters. So if an accessory is between 3 and 8 millimeters and it has enough length to put a treatment there, you should definitely treat it with the catheter. That's per IFU, so it's very clear. There are smaller accessories and smaller polar arteries. If they're under 3 millimeters, don't touch them. They're probably not significant.
All right, great. All right, PK, go ahead.
Just a couple of questions, I think, technically for Stefan and Hydrum. Yeah. So Stefan and Hydrum, when you look at this angiogram, right, for us at Sinai, we obviously see the distal vessels as to being smaller than 3, maybe 2.5 or so.
Right.
And then prior to that bifurcation, there seems to be a shorter stalk that are right just after the bifurcation that looks like it's a little larger, but is that enough room to land the catheter? Intuitively, for me, I would say that, I mean, again, we've done a few of these. We've done enough to say that we've done more than most people, but I would try to just just ablate the main stalk here and not
Right.
really go distal. But I don't know, and I guess that's part of the reason why we want to talk to you on how we should approach this. Is the spiral catheter too large to go into that? For instance, that stalk that's downgoing and then bifurcating. Is that okay to place it there? Because it looks like we might be across the bifurcation.
Yeah.
It's not that the catheter is too large. The catheter can actually go into a lot of places, but when you go under 3 millimeters, the blood flow changes, and all of a sudden the entire temperature relationship changes. So you're gonna have error codes for overheating, for example.
Okay.
So
From what I remember,
Sure.
Stefan, you gave a very great talk last time we were in Galway. At some point, I'm going to ask you today to maybe give a little bit of an abridged version of that, so we can really talk about the technology and why.
Well, I think they are going to talk about it.
Good,
Yeah.
good. And why the distal and mid is so important to be treated. But generally speaking, the idea is that if you treat up until the parenchymal shadow, generally at that point is when the vessels are going to be tapering down below 3 millimeters. So if you guys would also share your opinion on this, but I would actually consider putting at least one of the electrodes into each of those individual branches, because they do look to be greater than 3 millimeters.
if they are,
I don't know. I mean, I agree with PK. It's probably just borderline, maybe stretching ourselves and not really extending into those distal branches. But I mean, you could give it a call. But just from the catheter.
Why don't we do this? Why don't I introduce the catheter now as you guys talk? So right now I'm just gonna just give
Change
one little
the,
quick puff here just to tell you which branch the catheter is in, right? So you can see that right now the catheter is in that branch right there. So
Stiff wire.
So yeah, this is a
That's a run through.
That should be fine. It should be enough. It's a straight stalk. It should be
Right. So just talking about the catheter, does it come in different sizes, or is it one standard size, or how does it work?
Stiff wire. 100%,
Oh well. Yeah. So usually, like you say, it's just
we can talk about it here. I think this is one catheter that fits all.
side by side wire.
It's one catheter for both sides, 3 to 8 millimeters of vessel, and branches, accessories, anything. So it's one device.
one device. Yeah.
Single device.
Yeah, I think that's where the efficacy of the whole catheter comes in. You can use on both sides of the vessels and then treat it appropriately in all the branches as much as possible. I guess the important criteria you talked about is 3 to 8 millimeters, which you have to always consider. And like Raman was talking about, the denervation part is mostly in the distal part, like we talked in our presentation, where it's more closer to it, and that's where the real effect starts to happen. More proximally, the nerves start to really go far away. But in this case, you can see, I mean, the good thing is no branches, no accessory balls. The bad thing is it tapers very fast and very small. So I think our treatment length is probably limited to this main stalk, like PK was talking about, and trying to get the maximum effect on both sides.
And it's important to stay away from the parenchyma, as he mentioned already. And sometimes you may need a second projection because it's okay to be in the pelvis. And so the kidney is a horseshoe shape. So it might be a situation where you're okay, even though it appears inside the kidney, but you're not.
Yeah, right.
So
You could, and also to assess it a little bit better, you can also go like 20 to 30 degree ipsilateral. So that helps you sometimes to get a better view.
Right. So Heidi, have you ever?
You know, Hydram and Stefan, in this case with the creatinine borderline, I'm really hesitant to give a lot of contrast. So to me, you know, I'm going to take it for the way it is. And now we're just going to, we're entering the catheter into the body now. So just to let you know that it's a standard load of a stiff wire. We changed the wire to a stiffer wire, which is the Grand Slam. And now we're in a 7 French PK1 guide, which is a Medtronic guide as well. And we're going to enter in, and let's see, high impedance. Okay, that's fine. And now we're entering in, and I'm just going to have them just give a little slight puff for me because I just want to make sure which branch we're going into here. That's fine. I'm just going to go up to there, if that's okay with you guys. And then I'm just going to pull the wire out here, or should I go any further? What would you recommend here?
I think that looks...
You're still in the main here.
Yeah, I think you can go actually a little bit further because the catheter also foreshortens when you actually deploy it.
Yeah.
And it's easier to pull it back a little bit, but then instead of advancing it a little bit more
Correct.
distally.
It's easier to do it distal to proximal because
Exactly.
it's already curled in. You
Yes.
just
So
style
we're
it
just
as
going
up.
to give a quick test because we
Yeah.
have to here to make sure we're not across it to find out. Oh, okay, a little more than that. Yep.
So from the audience
There you
perspective,
go.
what's the
Yeah,
difference
well,
between the each electrode on the catheter?
So when it's actually deployed, we have a distance of round about like 5 millimeters between the electrodes. Yeah.
So we're just going to take a quick picture. That's it. So
Yeah.
we're across the
Oh,
branch,
beautiful.
but I think we're perfect. We can just turn off the last probe.
Yeah.
And I think the rest of it. So guys, can we talk a little bit about the monitor, Roman? Because
Yeah.
it's important for everybody to understand that we don't want to ablate across a branch point.
Yeah.
So we have two branch points there. You have the downgoing branch, which I think we're avoiding.
Yep.
And then we have the proximal branch, which you can see is also going to be avoided if we turn off the last probe number 5. 1, 2, 3, 4, 5.
4.
So 4. What
Four.
is it? 4.
Four.
I'm sorry,
Yeah.
4. I can't count.
So
I failed math.
So the the first one. So the first one is really at that distal point, and I think that one, for as Piki was saying, it's at a bifurcation point, but it's also where the vessel is becoming pretty small. So really, it's pretty intuitive. Kind of just push number 1. And remember, it's important. 1, 2, 3, 4 is not from the proximal to distal, but distal to proximal. So number 1
Right.
is the probe that is the electrode that is most distal in your actual spiral catheter. So number 1 we'll turn on, 2 we'll keep on. 3 we keep on. 4 I think is also okay. Yeah. So
12
keep
should be
that
fine
going.
too.
Yeah. So now, really
What
simple.
about number? I think we keep all 4 on there, guys.
No, one is off.
Yeah, one is
But
But
off.
we would
yes.
like to keep all 4. I think we'll keep all 4 of them on. I think we can.
Okay.
So one is right now is off on the monitor. That's why we see Raman.
One was
Yeah.
actually, we need to be careful that it's not on a carina. So
Yeah.
that is
Yeah,
probably the reason why they decided
one
to
is
deselect it.
off,
Yeah.
The one is number 1 is off intentionally.
Yes.
2, 3, and
Yeah.
4 we are keeping on.
Yeah.
So again, the last part of the device, it's just hit the RF button and that's it. Now, as a spiral catheter is doing the denervation portion, the machine itself is doing a lot of the work. Giving the sedation to the patient beforehand is super important. So we in this lab will do some general sedation with just some Versed and
So you can see we lost impedance on number 4.
Right.
this is saying because the
Yeah,
electrode
electrode
has
has
moved. Now, the amount of the anesthesia we give to the patient is pretty important because there is a little bit of discomfort that the patient will actually be feeling with this. So sometimes as the patient is taking a deep breath, the electrodes may be moving around a little bit. So a couple of things that can be done is to maybe take the catheter after this is actually done and try to maybe rotate it and see if
Correct.
you can get contact. Now, for number 4, in this case, if we're going to be we can just pull the catheter back and turn all 4 of the electrodes on and treat this
No, but we
particular
might want to go to
area
the
again.
top branch here. But a couple of things, guys. Like I want you to look at the screen. When you look at the screen, you have those lines. Maybe you can turn it on again, Roman, and we can turn off 2 and 3 and treat with 4 alone in this area. So we're just going to turn off 2 and 3 here. So yep. You have to first reset the catheter, right? Reset. I think it's the bottom button, right? Yeah.
No, you hit the
Yeah, right
reset
there.
on that side.
No, you go. No, this is red. There you go. Now turn
Yeah.
on 1,
2,
2, 3.
3.
Now we're just gonna treat in 4. So what I'm gonna
Try
do
to
is
rotate it a
just
little bit.
rotate it slightly
Perfect.
like
Correct.
that.
Yeah.
I'm
Yeah.
gonna clock it, and then wait. We're gonna look at the impedance, and you can see it's a 188. Guys, are you okay with that? Everything good with that number?
It
Yes.
looks very stable.
Yeah.
Okay,
Yeah.
so we're looking for stability, and Elizabeth is given medicine, and now we're going to ablate again. As Dr. Sharma said, what we're doing is we're rotating, and now I'm holding it, and obviously the pain starts around 45 seconds from our experience.
Correct.
And there it starts, actually, it's a little early for him. So you can see it, breathe out, sir. And the sedation protocols have to be worked out. We're trying our best here with the help of our Medtronic team to get the sedation protocols, but it's not the worst, sort of situation. That generally these patients have a lot of blood pressure that you can work with. You can sedate them quite low. There is no need for general anesthesia. And like Dr. Sharma said, 45 seconds of therapy is generally adequate, although you'd like to go to your full minute. And again, this is the situation here. So once we're done here, I'd like to play the angiogram. Ray, can you play the angiogram for everybody? And I want to just comment on the vessel below. So now, do you put the wire in that downgoing branch and then ablate that branch?
I think so.
The one going down.
The one going
Yeah.
down. What is it?
That one
I don't know.
That's small.
That's a small branch.
Yeah.
Yeah.
That's
I think the next
borderline,
we have
absolutely.
that
Okay,
upper
good.
branch
So we're going to
towards
go to
10
the upper
o'clock.
branch. So
The
what I'm
upper
going to do
branch.
is I am going to advance the wire forward as we talked and as everyone said. So we have ablated this area. I'm just going to now walk the catheter back like that. As you see, the catheter is very, very trackable, very nice. Now I'm just going to pull this back and try to go to that upper branch. God willing, that's it.
Beautiful.
I don't know if that's it. A little diagram. Oh, there you go. That's the
There.
one. So we're just going to give a little test, as Dr. Sharma said. And there, we're just going to go into that upper branch,
Yeah.
probably
I like
up
that a
to
lot.
there.
Yeah.
And
Now,
then-
in this case, if you remember, we've done where that probe 3 is.
Mhm.
That
so
one we
I'm
can
gonna
turn
I'm
off.
gonna pull this wire back, and we're gonna take a quick dive.
So maybe
What
just a
millimeter?
distal probe. Yeah.
Just 2 cc's. A little more than that. There you go. Okay,
Yeah.
so I think we're happy to do probe 2, 3, 2, 3. No, 1. No, 2, 3, and 4 and 5. 4, right?
4.
No. 1, 2, and 4. 1, 2, and 4.
Yeah.
Everybody okay with that?
Yes.
Because number
Yeah,
3
you-
is right
at the carina.
carina.
Yeah.
Yeah.
Okay.
Yeah.
Here we
Again,
go.
again, clocking. Again, it's very important to see the actual stability of the waveform, and so far it's been very, very stable. And as you can see, hold on, sir.
So in order for better apposition, do you sometimes pull the wire back a little bit to give a little bit of more flexibility for the catheter to form itself in the vessel?
So I think you actually have to pull the
Yeah,
wire
Right,
you have to.
right.
Yeah,
But
We don't
I mean,
want
how
to
far
have
back?
the
Yeah.
wire.
yeah.
All the way
You don't
back.
Further
have it.
back.
Correct.
Yeah.
It's further back is that
Further
what I said.
back.
Yeah.
Yeah. So yeah.
Generally, so again, this sedation is definitely a thing which is very important to try to manage it correctly.
Right.
Giving some extra before the patient is even on the table, being a little bit more liberal, as Dr. Krishnan was saying, the amount of room you have based off their blood pressure is actually quite forgiving. So you really
Right.
can be more than usually aggressive with your treatment. And we in this lab we use just fentanyl Versed,
Okay.
and it works
Right.
quite well.
So-
Now,
So
yeah, go on.
Now, so I'm just going to advance the wire, and then we're going to pull the catheter back and get the stock.
right.
So I'm just going to advance the wire. Anything that we should be doing different, guys, Stefan and but.
I think you.
So far,
So-
it's running very smoothly.
Okay. So just to
right,
talk about the numbers on the panel for the audience, what do these numbers depict? What are the numbers you want to have? What are the numbers you don't want to see? Can you give me an overview of just
Guys,
talking? Remember?
1 second. I'm just going to take a quick picture again.
Okay.
2 cc's, just to make sure we're turning on the proper one, and then we can go ahead and inject. Yep. I think we got to come back, right?
I'll go in a little bit.
Yes.
Yeah,
don't
you're
have to
almost out.
Yeah, so I'll go
I
in.
think we're leaving. soon.
Just a
Yeah,
touch
we
in.
got to go
There's
in.
a
Touch.
segment that actually has not really been fully
And how
treated.
much ostium do we cover here? That's another question. How close to the ostium am I able
Yeah.
to get? Right there, right? That's
Yeah,
good.
I like that.
Well, technically, you can go all the way back until the renal artery actually
Understood.
originates from the aorta. But Stefan, so
Five
is it
millimeters.
important?
Yeah.
Yeah.
So we're trying to avoid ostium. That's one thing that you don't want to induce morphological changes and start atherosclerosis or accelerate it a little bit.
Okay.
5 millimeters, 1 electrode length.
Okay.
So you
Same
want to
as-
stay away 5 millimeters, Stefan, just to be
Yeah.
clear
From-
for the audience?
Yeah.
In a case like that, because in a lot of cases you will see osteal disease, and
Yeah.
you stay away from the disease as well.
Yeah.
This is a very clean case,
Yeah.
so 5
A
millimeters.
lot.
Yeah. I think it's just the ideology of having the aortorenal atherosclerotic, which is almost at the ostium, because the disease really extends into
Yeah.
it.
Exactly.
So I think they just want to avoid it. I mean, like he said, here it's no atherosclerotic obvious lesions right
Yeah.
there. But even if you have something, it's just better to avoid it and just stay away from it.
Yeah.
Yeah, sorry. So just going back on those numbers, Stephanie, can you just go over them? What numbers look good, bad, ugly?
Yeah. So we are not actually specifically after a certain number or achievement, but what you see here really is a nice increase of temperature. So we have these in the blue, we have in percentage the drop of impedance,
Okay.
which for us is actually only an indicator that we heated up the tissue. It's not that we are specifically after a certain drop of impedance, but for us it's just like feedback that we really heated up the tissue. So a nice confirmation.
So that's your blue graph showing where the temperature has been consistent enough. That means
Exactly.
there's enough
You saw
contact and
on the
deliverable.
blue graph the temperature increasing, on the white line the impedance dropping. So
Perfect.
that's what you see on the
So
graph.
that's the ideal condition.
Yes.
One way to think about this is that you have two types of tissues in that environment, blood and vessel wall,
Right.
and they have different resistance electrical
Or
resistance.
oh,
So
yeah,
blood
just
has
different.
very
Right.
little, the vessel wall has high.
What you think? Yeah,
Anytime the
sure.
resistance goes low, that means the impedance is low. That means you're not attaching to the vessel wall.
Wow.
You have no contact. So, but every person has different numbers,
Right.
right? So,
All right.
So,
Good.
so Stefan, a couple of
yeah.
questions that we've been asked often. Like, we're doing this a little bit. I would say we're using both devices. They're both companies that are making it. So the question is, one of the challenges is how do we know we're adequately ablating on the table? It's the same thing with peripheral arterial disease. How do you know that you're adequately treating the vessel that's treating the wound? It's the same kind of situation. It's one of the challenges that we face. In the coronaries, obviously, you have FFR, you have other things to tell you that you've adequately treated the lesion, but here we don't. So in this question, is there a way for the doctors to know that they're adequately treating all the nerves and all the vessels they're supposed to be treating?
Yes, so great. Not directly, but this is a therapy where I always tell physicians that you need to be back to being a doctor. Don't rely on equipment, on your medical knowledge or anatomical knowledge.
Pull it back, we'll take
So a few
a
things. If you end up mapping and treating the entire length of arterial tree between the aorta and the kidney, and you particularly hit the distal segments of that tree, regardless of the bifurcation is, between 3 and 8 millimeters, you can actually anatomically in your head say, I have gone through this retroperitoneal space and I've treated the entire space with bunch of ablations, and more importantly, I was in the distal aspect of that anatomical tree. In that case, your medical judgment should allow you to make a call that I'm done.
We're done.
Right?
Yeah.
And so that's what you're not relying on a machine, you're relying on your medical and anatomical knowledge to say, I've treated a space.
Right. Okay. Great. So, have you ever has anybody thought about using, let's say, IVUS sizing, like how we were discussing, whether it's borderline, whether it's 2.5, whether it's 3.1? Have you ever thought or seen anybody do an IVUS of the artery to really define the anatomy, or is just purely angiographical?
So in all our clinical trials, we have just gone by angiographical assessment.
Right.
And then also the electrodes itself, they have a diameter of 1 millimeter. So if in doubt, you can still use the electrode
As the
as a
reference.
reference.
Yeah. That's amazing.
So again, we've just wired into the other vessel. Now, Dr. Sharma and I are just going to. The question here is, so if you look at the top vessel that's going straight
This is a longer
to the apex of the kidney, do you treat those 1, 2, 3 branching points, or do you just treat the stalk?
Stalk.
Mainly
Yeah.
the stock. Yeah.
Because also you can see the parenchymal shadow quite nicely.
Yes.
Yeah.
So I think in this case it really does. If wish there was a way we can kind of outline it, but unfortunately.
Yeah.
I'm never too good at this Phillips machine, but there is a pen that can actually be used.
So I'm going to advance this, like we said, and hold on, let me get out there.
Yeah.
About maybe up to there. I like that. And I'm just going to pull out. There you go.
Yeah, and when the tip is in, you're going to have an extra 5 millimeters, and your first electrode is just right now. You can still see the actual parenchymal shadow right now. If you guys can see, yeah,
Yes.
you actually
Yeah.
can.
Yeah,
we can see it.
very nicely. So we see that the tip is probably right within the actual parenchyma, but then the 4 probes, the 4 electrodes are very well situated inside there.
So before you start, I just want to look at the impedance. Again, the Hydrum, I know for the audience, this is foreign. And Stefan, talk about the impedance. What are they looking at? What are the lines? Tell me what are the warning signs that you're not well opposed? What are the warning signs that the good signs that you should start?
Yeah. So as I said, we are not looking after a specific number of impedance. We are not looking for a specific value. But what you see here very nicely is that we have a very, very stable line. So the graph is very stable. We don't even see just like bumps with breathing. So that lets us assume that we have very good contact to the vessel wall. So that is what we are looking for. So not for a specific number. And even when you look at the number, you also see it's not fluctuating much. They're very, very stable.
Right.
So all indications that you have a good contact here.
So great.
Yeah.
So before we're going to start, because I mean obviously this is like watching paint dry. What we're gonna do is Dr. Sharma and I I'm just going to show this angiogram and tell you what we're going to do while you guys talk and do your presentations, because I know are very important to this program. So we're going to ablate that prior to that first bifurcation, the distal area. Then we're going to pull back, put the wire into that larger downgoing branch, and then we're going to ablate that area. Then we're going to pull back and ablate the ostium, or near the ostium, as Stefan said.
Right.
And then when we're done, by that time, you guys would have presented, and then we can have a discussion. You keep an eye on what we're doing and tell us if you would do anything different. We are going to clock the catheter if we have any drop in impedance, and obviously we're going to make sure we don't burn or ablate across any or denervate across any branch points. Okay.
Right.
All right, so we're going to get started now. Liz, some medicine, and you guys can get started with any presentation or anything you guys have. Oh, 1 second, they're booting it up, so we're going to start. Go.
Okay, here we go.
Little die.
Yeah.
You did test, right?
Yeah.
Okay.
Yeah.
It'll be interesting to
Yeah.
see that distal branch, how it goes,
I know.
because it's on the borderline of the diameter,
Exactly.
so they might get some hot temperatures.
So
On
it
the
might
one,
just
on the inferior, going
and the
down.
inferior.
Yes.
I think
Yes.
the lower one, as it makes that a turn.
Turn.
I think the goal would be to get the wire beyond there and probably get the first 1, 2, 3 electrodes in that descending portion, but then don't bother treating anything distally as it
Yes.
actually
Correct.
makes the
Yeah.
actual
Yes.
turn.
Yes.
I want the audience to see at home. I mean, the beautiful thing that Hydram described with the impedance so stable, even though he is having a little discomfort, Elizabeth's doing a great job with sedating him, and you can see here that there's really no drop in impedance and a turn off of one of the electrodes, which we're very happy about.
Very nice. Yeah.
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 This is probably as well one of the nicer examples, because usually, again, it's this movement and shift of the catheter and change in the impedance will happen as people are in pain. A deep breath in just like that changes your entire anatomy, and it really does result in a big change. So now we see here that 3 and 4 are right beyond the actual bifurcation point. So PK is going to send the wire across, pull the catheter back, and very elegantly wire into that
the
descending
lower
branch.
branch. Yeah.
Let's see, here we go.
I got to pull the catheter back a little more.
Beautiful.
There we go.
And right across.
I'm just going to go as distal as safely as I can, which is probably about there. Then I'm going to take the catheter down. I'm going to go a little bit more.
I like that perfectly. Yeah.
Yeah, that's okay.
Right there.
And then you see right now how the wire is in there, giving the extra support. When you pull the wire back, it is going to foreshorten a little bit. So it looked like that probe number 1 maybe was a little bit too far.
I could probably go in a little bit.
Or pull back.
I think that's no. I would not go in a little bit more.
What do you say?
I would
pull back a millimeter or so, or maybe just turn probe number 1 off.
Exactly.
1
and number
maybe even 4.
Yes, correct.
Yes.
4.
Yes.
I would
1
turn
and 4
off, for sure.
1 and 4.
So everybody at home, that's very important what we just discussed. You can see that what Stefan was saying is that the temperature can get too hot distally when the vessel is small. So it's a clinical judgment call, as he elegantly said, where you have to make that judgment. And 4 is obvious because you're across the bifurcation. You do not want to do this particular sort of therapy across a bifurcation point. So I think this is very nicely done. And,
So Stefan,
are we ready for the presentation, AVT?
But let's say hypothetically somebody doesn't turn off 1, and they think probably will be able to get away with it. They don't turn off 1. As a safety measure, do you think the impedance, when it shows up, it turns off by itself?
If it gets too hot, it will turn off by itself.
So that's like the safety. So that's a good safety parameter in case, let's say, your judgment was, oh, maybe it'll work, and I don't turn off my most distal end, and suddenly it's too high.
The algorithm will protect you on both ends. If it's too cold, you're not doing enough good ablation, or also if it's too hot.
Yeah.
So
Something that's very important to note is just we can there's still a safety net before anything else really happens that way.
One thing though, if I understand correctly, if let's say in this sense we correctly turned off number 4, because not only did we already burn in that area, but it was also near a bifurcation. There is no system in place for the actual generator to turn that off. Is that correct? So that's going to be more of a visual memory thing, keeping in mind where you have previously treated.
Clinical judgment. Yes.
Hold on.
All right.
Is this too close to the ostium, Stefan?
I think that's
I think we should be.
Number
Number 4 is close.
Yeah.
Okay, I'm going to push the wire out slowly.
Yeah.
or we can just turn 4 off and just do 1,
Yeah,
2, and 3.
exactly.
I think this is good right there. This is
Yeah,
good.
because we already
Oh, wow.
covered that segment.
Yeah.
It will come
So,
back
so,
when
It
so
you.
comes
this
back.
actually is really interesting. So this
Yeah.
Foreshortening.
portion is this proximal portion of the renal artery is larger in caliber than the other one.
Absolutely.
Yes.
Yeah.
And we see what is the capacity of this device to accommodate to the actual vessel size. So this is clearly a much bigger vessel. And we see how much this catheter wants to foreshorten to take
So I
its
think
original
we're gonna
prepackaged
leave.
shape.
We're gonna leave 4 off and do 1, 2,
Correct.
and 3.
Correct.
Yeah, that's why we
Yeah.
were talking. Is like
Yeah.
do
We
4.
agree.
I
Ready?
agree.
Are they ready?
I think that's a great feature because
Yeah.
that gives us protection. So the minimal
Yes.
catheter wire movement will probably cause minimal trauma, and at the same time, you can control your sections of
Absolutely.
ablations
Yeah.
by turning 1, 2, 3, 4, all one or few off. So I
Yeah.
think that's a great feature to look into and then utilize to your own
Yeah.
advantage. So here you can see like the blue curve, which is the temperature like Heidi was
Yes.
talking about, consistently,
nice
smoothly
increase.
going up, and then it's going to stabilize or flatten out, meaning
Yeah.
that there is still constant delivery of your energy, and that's what's causing the temperature to go up.
Yeah.
So
And that exactly. And you see the generator actually ramps up the power over the first 10 seconds.
Yeah.
So that's why you also see basically a step up
Right.
approach in temperature and drop off impedance. And then it tries to maintain this 1 minute ablation. And the algorithm actually adjusts accordingly to the values that it's getting.
correct. So what about the electrode 3? See how there was a little bit of drop in that
Yeah.
temperature going down?
That's in the most open vessel, so it's getting a lot of blood. And
So
you have to
that-
remember these electrodes are gold, so extremely conductive, and so it's getting cooled a little bit more.
Right, so that's why you can see
Yeah.
electrode 3 having a slight drop in pressure, even though it's maintaining its
Exactly.
pressure, but not as much as the 1 and 2 for the
it's still
contact.
above the temperature that we require for ablation. This entire case is beautiful and shows the versatility of the device, but again, it has to be coupled with the clinical judgment.
Right.
You cannot be an operator in this case. You have to be a real physician when you use this device.
So do we have the slides or?
So
Yeah,
we
I just saw
we
them.
have the slides, and what we're going to do is, since we're done with our ablation, we're going to pull this back, take a quick picture, and then after the slides are done, we're going to go ahead and talk about post-management. So here's a picture.
Yeah.
We're just looking for any spasm, right? That's what we're looking for.
Yeah.
So no spasm. The vessel looks really good. Take a look. So with this being done, I think we're okay. We'll look at the distal vessels, no perforation, no spasm. So I'm going to walk my wire out and then just take my catheter out of the body, and then we can go with a wonderful presentation and we can have a discussion. So let's go to the presentation.
Yeah, you couldn't have ordered a more beautiful case for this.
Perfect anatomy, yes.
This is a very, very
Tips, tricks, and techniques.
Amazing
good
case.
Right.
Okay, well, so again, my name is Stefan Tunev, and I'm gonna show you for about 10 minutes, maybe the very basis and some data for the Symplicity Spyral Renal Denervation therapy as developed by our company Medtronic. And again, with my fellow moderators, maybe we'll have a little discussion on the slides. On the right side here, I just came back from Boston, from Beth Israel Hospital, and this is a case we did there. And we can see how we take our sales reps and support staff takes the time to actually map. And this is some of the more complex anatomy that we saw 2 days ago in Boston, but makes a beautiful presentation when you look at this. I just took a snapshot of the staff notebook. Okay, next slide, please. My disclaimers. Next, please. Okay, so why do we do this? Obviously, we're going to do some harm to the body, but what that harm translates to is that we disconnect the talk between the brain and the kidney in terms of sympathetic signaling. That sympathetic system in the kidney increases renin release directly to the renin-producing cells, which in turn activates additionally the RAS, the system. It directly affects the proximal tubules and causes them to reabsorb sodium from the pre-urine. So now you have more sodium in the body retained, and that retains more water. And it constricts the distal renal artery flow, which is basically what you did not see in this case. We're talking about the pruning. It is because of distal disease.
Right.
Those arteries, you can imagine, when they constrict, there's a significant decrease in flow. Combined, these three things actually cause high blood pressure. So the idea here is to say, okay, we're not going to allow the brain to do that, and therefore the kidney will not receive those signals. At the same time, the same bundles that we ablate, the same renal nerve bundles, they also contain nerves that carry signal from the kidney to the brain, the afferent nerves. We disconnect those too. Not only the brain cannot tell the kidney to increase the blood pressure, but also the kidney cannot tell the brain to affect other organs to increase the blood pressure. So both ways. So that's basically the goal of this, to disconnect that phone call that's happening there. And we want to do it very specifically. We don't want to affect kidney function, ureter, ganglia, mesenteric function, all of these other things in there. So it has to be very specifically done for the renal sympathetic nerves. Okay, next slide. A little bit of anatomy. Our species, Homo sapiens, is extremely variable in terms of kidney development and what kind of arteries we have there. And we have, in this particular case, you can see a very short main with two big branches. Almost if the main was a bit shorter, it would have been duplicate renal arteries. And you have a very large, in this case, accessory. All of these vessels are well innervated. They have to be denervated in this case. About 30% of people roughly have accessories. So you're going to see it every third case, basically. You're going to have an accessory. So look for the kidney shadow. That's very important.
Yeah.
And also you can see how these nerves, the yellows are the nerves, they come off ganglia, which is the big bulk mass on top. And in this particular case, very nicely demonstrates that the ganglia is not very close to the aorta, and the nerves do not follow the main renal artery, but they kind of come in a bit late in the course of the renal artery. We call them late arriving nerves. That means you have to denervate distal. And again, I was making the point earlier that use the bifurcation as a landmark to decide what's distal, what's proximal, but you can also, as an alternative method, to ignore the bifurcation, look at the aorta, look at the kidney, divide that space into thirds. That's your retroperitoneal space. The renal artery is your highway, your path, and you say, I'm going to denervate the third portion of that space, and the middle portion. If you do that, you're going to be very successful. The proximal is not that important. So in this particular case, that very nicely demonstrates that. In accessories, we find out that they're typically straight. They may have one or two branches, but they're smaller, very straight. And the bigger the accessory, the more nerves they have. That's kind of natural relationship. And so you're going to see all sorts of variations on these trifurcations, long main, short main, everything else. The good thing is that we have designed a device that can go in all of these anatomies, except if you have diffuse disease or FMD, on any diffuse stenting, or if you have aneurysms, don't go in this kind of pathologies. Okay, so let's go to next slide and look at some nerve distributions, I believe. Okay, so published by multiple groups, and we studied this extensively throughout the RDN development, where the nerves are, proximal on the right side, all the way to post-bifurcation, cross-sections in human cadavers. This is pathology. And the yellow dots demonstrate where the nerves are, basically as studied by pathologists on slides. And you can see in proximal sections, they're all over the place. And as it goes distal, they get really, really close to the renal arteries because they have to enter the kidney through the same door, through the hilus. Now, one other important thing here is that if you start counting these nerves, if you have good graduate students and fellows in pathology that have good eyes and time to count nerves, you're going to see that the nerves in the proximal sections are a lot more than the nerves in the distal sections, which indicates that a lot of these nerves, or maybe a good portion of them, are not renal. They're going somewhere else. And that's a very highly innervated place there, the retroperitoneal space right to the mesenteric. And so you also, I said earlier, we have to be very specific. We don't want to denervate anything else.
Right.
So distal is not only the nerves are closer, but they're also specifically renal nerves. Two very important points. Okay, next slide. To look at that. Again, we're going to repeat a little bit of this. We have a very compliant catheter, self-forming, 4 gold electrodes here. This is the generator. We talked very well, and it's a depiction of how this catheter fits. And again, it can make different configuration of helix depending on the vessel diameter for that. Okay, let's move on. I think we need to jump into the clinical data. Next slide, please. Oh, this is more, let me just say, this is 6 French catheter. I believe Record is a 7 French, so or 14 guide wire. And radio frequency is monopolar, so don't forget that
the grounding.
The grounding, right?
Yeah.
And maybe, I don't know if you have discussion, but I think different centers have different preferred spots. Some do leg, flank, back, things like that. I don't think it matters that much. Hydran, do you think? Where you put it?
Well, usually we like to have it on the upper thigh.
Upper thigh.
We like to have the shortest distance between the electrode and the grounding pad if possible. Yeah. That helps with the impedances.
And what about size of the grounding pad? Do you care for that?
We have in our IFU, there's a specific instruction on which grounding pad to use.
Attention.
Yes.
Yeah. Okay. Very good. And the tip, you can see the tip is radio opaque. platinum iridium. You could see it there. It's not electrode number 5. It's that. It's the
For
tip.
just a,
Right? Some people may think, or 0.5, but it's very soft. It's actually non-traumatic. So very nicely designed. So plug and play, but don't forget that we saw earlier in this case is that you plug the
outside,
device
yes.
and nothing happened until you enter the patient.
Correct.
So if you don't see anything, forget, you have to get into the patient to get the display to turn on. Okay, next slide. Okay. I think we covered this a lot.
Yeah.
Okay, so let's go to clinical data next, I believe. Enough of the technicalities.
Next slide.
Next, please. Oh, the magic slide. Okay, secret sauce. I talk a lot. This is one of my favorite things to talk about. But why this therapy works? How it works? Basically, we found out that the nerves, the renal nerves, being in the retroperitoneal space, they actually exist in an environment of fat, of adipose tissue. The retroperitoneal space is very, very fatty. In fact, when you do a dissection, you're not going to see anything. You're just going to see fat until you start removing the fat to go to the kidney. So fat has a different resistive index than other tissues. It's very resistive, so it has a high impedance if you measure it that way. That means that you can pass a current through it that will heat the fat preferentially without hitting other tissues if you carefully design that current and the electrode size and everything else. And that's exactly what we've done. Our therapy induces heat in the adipose tissue specifically, and it does not induce heat in the renal vein here, RV you can see, or lymph node, LN, or other arteries. And the nerves are in the red, and so basically they get ablated.
Right.
What we call a pathological lesion, in this particular case, the pathologist identifies the black line and draws it in there, is the inflammatory changes and fat necrosis in the fat. Once you disturb the fat cells, the fat leaches out, and it's very pro-inflammatory, so macrophages have to come and clean it up, and you can identify that from normal fat and say, aha, this has been cooked. So cooked fat looks very different. It's very similar to pancreatic cancer, for example, when the fat also is damaged by the enzymes. So the lesion is, so to speak, a smart lesion. It curves around the vessel, spares the renal vein, spares the lymph nodes, seeks out the fat, heats the fat, and if there are nerves in the fat, they will get ablated. You can see here in the top portion, there were no nerves. Importantly, the last thing I'm going to say is it's also designed to induce a very minimal ablative damage in the medial wall, less than 20%, and that heals very fast. Not only is minimal in terms of distribution, kind of a circumferential distribution, but it's also minimal in terms of severity. And that's very important because we don't cook the collagens, we don't thermally ablate the collagens to the point that the endothelial cells can no longer recognize them as biological substrate. And what happens in this therapy, the reason you don't have stenosis, the reason you don't have thrombosis here is that endothelial cells can recover very quickly, and the collagen, even though it's exposed briefly after you ablate in that spot, it's not prothrombogenic. So it's very finely tuned device and therapy and energy together to balance safety and efficacy and durability for that. Yeah. Okay, finally, I'm going to go to clinical data. We can talk a lot, but it's important to look at the real results, right? Okay, so next slide, please. Okay, so we have a lot of clinical data. It's very difficult to summarize it in 10 minutes, but our current clinical program constitutes of the trial called OFF-MED. So obviously OFF-MED, we removed the medications from the patient regimen for a period of time and renal denervate them. On MED, that's renal denervation with drugs. They're both sham controlled, and we have this huge registry, global Symplicity registry trial. We like to measure things in patient years, so you can see here our data spans over 12,000 patient years. I believe there were over 4,000 patients, and all of these studies have both safety evaluations built into it, right? So to see. Okay, next, let's look at some actual numbers of next slide, please. Okay, so this is 3 months at the Symplicity off med without, and 6 months the Symplicity on med, and you can see in both trials we are approaching 10 millimeters of drop on average, right? Do you want to do any comments here?
No, I mean,
what does this mean to you?
I mean, clinically, I mean, we all know there's enough data to show that there is mortality benefit by decreasing a systolic and diastolic pressure based on all the trials. So having a blood pressure down with this device, in addition to your guideline-directed therapy, actually really helps the patient, or should help the patient long term. Of course, the data has to be followed for 3-5 years to really substantiate, because we as cardiologists are spoiled to getting long-term data. So
Correct.
short-term data, people are like, yeah, okay, whatever. But I think the trend and the absolute number changes of drop in your blood pressure is significant, both from a clinical perspective and hopefully from a long-term outcome as well.
Yeah, very well said. And in fact, I mean, the one of the dirty secrets in our field is that the short-term data is for the FDA, and the long-term data is for actual physicians. So you're absolutely correct, and that's what follows. So let's look next slide. So it's an important thing to realize what the effect is during the day, right? Let's talk a little bit about here. So you have here in the blue lines, you have the baseline, and in the black lines, you have the follow-up. And this is at 3 months. Again, this is data for submission. But you have that nice drop of the follow-up, that the blood pressure now is lower. The most important thing is there's a slight dotted line, vertical dotted line that separates at 7 o'clock. This is 24 hours. And you can see how in the time between 2 a.m. and 6 a.m. you have a nice drop, and that's the critical time of the patient's life, right? So to have that nice effect in contrast to drugs, I think it's very nice to have.
Definitely,
right? Okay, so next let's look at. I think we're going to jump into the long-term data, right? So the real stuff. Okay, very surprising for this therapy. There are very few things in the medical world that improve over time. Most therapies and surgeries, they get worse over time with complications, but this one goes on the opposite direction. This one becomes better. So we were 9 millimeters, now we're 18 here at 24 blood pressure, and the office blood pressure is at 20, very similar values. We don't know exactly how this happens. It's a very complex physiology. There's probably some adaptations going on in the distal arterial tree in the renal in the kidneys. We're not certain. We have to study this, but that's the trend, and we're going to show data along many trials that with time the effect of this therapy improves. And there are 2 levels of improvement. Number one is people that responded with X amount of millimeters drop, they have higher, but also people that did not respond in 3 years, all of a sudden they respond after at 3 months, they respond in 3 years. So 2 kind of different improvements.
Interesting,
right? Okay, so go to next to see how that 24-hour looks. Now you can see at 3 years that separation actually is getting really marked, and you are accumulating an incredible benefit to this patient. I mean, on average here now you're back to 120, so they basically normalize this patient. So that's the real thing that matters for doctors. 3 year and beyond, this is what you get with renal denervation. Of course, it's important to reevaluate the pharmacological regimen for these patients and adjust it to whatever they need. But that's the other benefit. You're going to reduce the drug burden in the patients. Okay, next. Okay, now you can see how this is across different trials. On-med pilot that goes from 1 year, 2 year, 3 year, and again the effect I was telling you that deepens. You can see 12, 19, 20, but the same thing happens to the global Symplicity registry. And then of course the biggest surprise was that HTN3 trial. I'm just going to touch base on that. We did not think it worked very well, but that was a short time, and again doctors say show me the long-term data. Surprise, surprise, it works.
Yeah,
right. And if you look at the global Symplicity registry by itself, next slide please, in the long-term data, because that has the most patients, very nice to demonstrate that deepening of the effect from 6 months to 3 years. And so this therapy is magic to me. Very nicely done. Okay, next, let's move on. Okay, not only we have our own trials show that, but our trials exist in a landscape of many other independent trials. And you can see here on the left side we have the HTN1, HTN2, and all the way to on-off met and registry. But then you have all these other registries. Of course, they're much smaller patients, but they're done by independent physicians and independent groups, and they're demonstrating very similar drops. These are probably they're not sham controlled, and they're not basically randomized and all that stuff, but the bulk of the drop is that. And the important thing is now if you go to the right side, we're seeing trials at 8, 9, and 10 years. That tells you that durability of this therapy has some longevity to it. We have not looked into should we repeat it in X amount of
Yeah.
years, but that's another clinical discussion we can have with our partners like yourself. So very nice lengthy therapy with a substantial effect that increases over time. No side effects. No side effects. That's across all the trials. Okay, I think we'll have one more slide to show you about different populations, which is very interesting. Okay, so if you look at here now across different more comorbidities basically, but across all of these you have diabetics, fibrillation, chronic kidney disease, elderly. This is basically a universal therapy. Let me open for discussion here because this is an interesting topic. Do you see a lot of these different patients in our clinical trials, or we don't? We include a lot of.
Well,
Yeah.
these are patients from our global Symplicity
Registry,
registry,
yeah.
which is definitely more real world compared to our on and off med data.
Yeah.
But I think, especially when you look into the elderly group of patients, which are of our interest, or also like patients with isolated systolic hypertension, or
Yeah.
even the group with, although experience is a little bit more limited, but with chronic kidney disease, which are actually the patients that we all
Correct.
have in mind.
Yeah.
And I think these are very reinsurance reassuring in
Yeah.
results. Yeah.
Yeah, I think that's a good slide to present, especially on the population we actually encountered. The
Yeah.
trials, the registry gives you a little bit more truer picture as compared to the
Absolutely.
randomized trial because you want to get the best of all the patients. But you can see a consistent effect across the board, across various medical conditions that the patients might have. Of course, like Heidi talked about, having chronic kidney disease is one of the compounding factors being there, especially a lot of patients with CHF, which have a renin-angiotensin axis is completely
Yeah.
spun in the air, which nobody knows what's going on because of the feedback. I think it has a major implication in that subset of population for sure.
Yeah.
And I think we can talk about that later.
Yeah.
But I think great presentation to see how the therapy does work and across the board and including follow-up on long-term data as well.
Yeah. And I think this is the last slide.
Okay, good. So I think,
Go back to the case.
yeah,
Thank
perfect. Well, we can hear you,
hear
PK.
you.
1 second, PK.
Okay, hold on.
Yeah, now we can hear you. Yeah, go ahead.
Stefan, that was really a tour de
Yeah.
force. Thank you again for that incredible presentation. Just a couple of questions. I mean, was there any way, why do you think, in-office measurement was not, versus, 24 hours, there was not a statistical significance? Is that an important thing, or you think that was a statistical issue? Why do you think that happened? I mean, there's always one thing when they say that one of the primary endpoints wasn't met, and that's what I was curious to ask you on that.
Yeah, well, so blood pressure, as you know, can vary minute to minute. It's a tough thing to pin down, right? And so office to office, and who takes the measurement, what apparatus, how they do it, did the patient have the proper rest, where's the arm, all of these things. Did they go to the bathroom, for example? That's you can
I can
drop
do it too.
right. I can do it
Yeah.
too, right? And so we were looking at a very elusive animal here to pin down, right? Whereas the 24-hour increment gives you a lot more
Exactly.
better picture
I
for
totally
that.
agree.
Yeah. So
Raman?
Yeah, the other thing is that this really is a remarkable change. With a lot of the pharmacologic therapy we have, obviously we know you give the pill besides like amlodipine or so, you get the effect by later on that same day.
Yeah.
But having this delayed response and actually an amplified delayed response really is something that's very, very beneficial. But as you said, very unexpected. My question is, in some of these longer term data registries, when there are 5-10 years or so, are we seeing a plateau in this eventual drop, or does it keep on dropping for 10 years? I would assume that at some point it must plateau, right?
well, we don't have, I think, in one single register goes 1, 3, 5, 6, 7, 10. They're all on different times, and so I think that we don't have enough data to actually answer your question directly into one single trial.
But that
So-
one slide you had about
Yeah.
the other registries, towards the end of did I misunderstand that these data, that these registries were spanning for 10 years, or these are just
Only some.
Only
It's
some.
yeah.
okay?
Only some of them.
So you need
the
to do it
latter half of
properly,
the
yeah,
right side.
exactly.
They don't
Yeah.
have any data. I mean,
Yeah,
Right.
yeah.
I would hope at some point it does plateau. The last thing we want
Right.
is to make
So,
it hypothetical.
Stefan, one question for you and Hydrum. I mean, how can you explain that? How can you explain this delayed response?
Well, I'll take a stab at that because I want to spend the rest of my career trying to answer that question. It's very interesting. But so when you talk about plateau, you have to think about we have multiple mechanisms in our body to regulate blood pressure, and we're not lowering blood pressure in this particular case, or even with drugs, we're trying to normalize blood pressure, what the body thinks the normal blood pressure should be, 130 maybe, right? So it cannot indefinitely continue to drop because at
Right.
some point,
You have to have a
right,
hemostasis.
yeah.
Right.
And so I think what's happening in the long term, the body continues to adjust until it reaches a point that the body decides, okay, this is my normal, quote unquote, for that particular system, blood pressure, and that takes time because it has to do any physiology, you need to have a morphological changes in your body, secretion of hormones or adaptation of blood vessels or sympathetic signaling. All of these things have to come together, and I think each body is different, each patient is different, and they have to decide physiologically. The physiology has to decide, okay, where am I going to stop? And that path is different for everybody, but it's not indefinite. You're going to reach a point that the physiology will say, this is my quote unquote normal state.
Right.
Of course, the
Right.
drug is gonna switch.
Yeah,
Yeah, go ahead. Yeah.
Yeah, and I also think, and this is what keeps the therapy so interesting for me, is we still have so many things to learn, and I think this is one of the questions that we still
Right.
need to find a very good answer for. So we are looking into very different ideas, but the truth we haven't detected
Yeah.
yet.
Awesome. Right.
One thing I just want to comment. I know Dr. Sharma, myself, and Dr. Kapoor tells speak to our patients about this. This is not a cure. This doesn't cure hypertension. This doesn't mean that you can stop your medications the moment you have this particular procedure. It is very important for the doctors also to understand who are watching, not to tell their patients that, hey, it's going to change you're going to cure your hypertension. It's not the case at all. The one comment I do want to ask is, and I want to ask Dr. Sharma and Dr. Kapoor as well clinically, and then maybe both of you can pitch in. What is the long-term anticoagulation? I mean, do we use aspirin and Plavix? In this particular patient, what is the endothelial dysfunction that occurs? Is there any risk of late thrombosis, so on and so forth? So Raman, first, what do you use in terms of your anticoagulation strategy, or what's recommended? Let's start with what's recommended, Stefan.
Yeah, what's recommended, Stefan?
Yeah.
So in our clinical, in our clinical trials, we have given like 4 weeks of aspirin.
Yeah.
So no depth, nothing in this matter. And then if the patients were not on aspirin for 4 weeks, that's it.
Okay.
Right.
And a lot of these patients will be on aspirin for a different diagnosis as it is. So generally speaking, there's really no change in pharmacologic therapy. I'll put these people on.
Yeah.
And that's the reason you said late thrombosis doesn't occur, but the reason they're in short term because of the endothelial recovery is very quick.
So
You spoke about some injury occurring to the endothelium,
Media,
and so that's the reason I asked that question.
Yeah.
Right. But PK, as a part of your protocol, the procedure is done. What's your follow-up of these procedures in clinic based, especially thinking about do we repeat a renal ultrasound to see if there's any damage? What about clinically? Like, how do you follow these patients as an outpatient?
Well, in the ones we've done, I know we all pretty much similarly don't do renal ultrasounds routinely. There's really no chance of renal artery stenosis that's been reported or anything to worry about of any significance. We do follow blood pressures very closely. I'll see the patient 1 week or 2 weeks after the procedure, depending where they live. Sometimes they come from far away, and we'll have a phone call, obviously within 48 hours. 24 hours in the cath lab is our protocol, but our team will also call them within 72 hours just to see how they're doing. It's important because a lot of times the patients stop their medications. And
Right.
It's an education thing for the patient to really discuss with the patient that no, you cannot stop your medications. That yes, your blood pressure may be labile and maybe up and down, but contact us. I think that's one of the things. We did have one patient, and we all have that one patient whose blood pressure drops very, very quickly. And she actually became very hypertensive, dizzy, so on and so forth, and had an admission to the hospital because she continued to take her medication. So that's very rare, but as exactly as Stefan said, the body completely normalized that, and the patient became very stable on less medications. So I think that it's important to educate your patients post.
Right.
Excellent.
No, I think I
important,
agree.
very important.
It's like you're
Yeah.
balancing your expectation of a patient versus the clinical outcome. I think is very important in these cases.
And I would add that we also need to educate the hypertension specialists that refer these patients to you, because they're the ones that are going to look at this patient. They're going to do the pre-work, and the post-work is very important, and they need to understand that and dial back the therapy in various forms. So
Awesome. All right, great. Perfect.
This is
All right.
also all really coming in at very, very good timing, considering this is on the heels of the temporary new technology approval coming in by CMS, which will be coming into effect in October 1. So
Yes.
now we'll be having inpatient reimbursement for this as well as for
No
recourse
question.
denervation. So there's a temporary code that is now will be being provided
Yeah.
about $14 or so thousand for
I
all
think
inpatient procedures.
I think that's an incredible point Dr. Sharma is making, because
yeah,
the reason we don't do this more often
Right.
is obviously the reimbursement is very difficult. Currently, it's a challenge, and we're doing our own analysis. We've all done quite a few cases, but we're doing our analysis, and we actually have a meeting later on Friday about this to find out what the reimbursement is. So I think it's individual within the institution to set your protocols. We're very conservative. We have a lot of patients who are following with this. I know Dr. Sharma, Dr. Kapoor all want to do these patients, and even this was, I think, the first patient we've done in the last month. So it's quite challenging to get approvals for this, but I know that, as Dr. Sharma said, this is going to change because there is so much benefit for this particular, and the data really supports this therapy. One question, and I know maybe both of you don't want to answer this, but I'm curious. So the competitive device, the Record device, I know you're not experts on that, but I'm curious. That particular device uses a different form of delivery of the therapy. Do you think it matters how the therapy is delivered, whether it's through a balloon catheter or through a spiral catheter? Do you think there's any benefit to more circumferential ablative therapy with the balloon versus what we're doing with this particular catheter? Because their data obviously is not as long term as yours, but clearly they do have
yeah.
some exciting data as well.
You know what really matters, and it's a good question, and we need to talk about it, right? And you're right, we have an experiment with that device. But what matters most is the environment. You are going to be entering an extremely variable, heterogeneous anatomical environment. And having a device that works in a heterogeneous environment is one thing. I think the Recor is well suited for a very long main that is non-complicated, straight vessel. You can put 2-3 balloons there, 3
Yes.
preferably, and that's going to work, right? And so if you find patients that have that on both sides, uncomplicated, yes. And that's where the difference is. It's in the other side, not the device.
Right.
So,
Versatility of it, yeah.
but
Yes.
exactly.
Yeah.
But
Yeah.
also
Yeah.
the
I think the
strength of
anatom.
the data,
Yeah.
clearly is with the Spyral device. I mean, you were talking
Right.
about 10 years, as Dr. Sharma alluded to.
Yeah.
You're talking about incredible data out to 10 years. So I think the long-term follow-up is there. So I think it's important for everyone to get well-versed with the data. And my advice to everyone at home is to attend the Medtronic sponsored innovation symposium at our conference, because we have an exciting faculty, like I said, and they're going to be discussing all these and other nuances. So if there's no
Perfect.
further questions, I think, Vishal, I'd like to
Yeah.
thank you and the team for coming there, and maybe you can sign off and invite everybody
Yeah.
to our conference.
Exactly. Perfect. All right. Thank you,
Thank
PK
you.
and the team. An excellent case presentation on one of the latest technological advancements in the field of cardiovascular disease, I think, which is going to make a great impact. So it's always good to be at the forefront, learn, teach, and be a part of the team which collaborates. Especially thank you, Medtronic. Thank you, Hedy. Thank you, Stephen, for being here from your busy time. But thank you, everyone, for joining us. You can see this case again on our website, ccclivecases.org, in the peripheral endovascular section under archive videos, and any of the previous videos you might be interested in, or you can email us for any questions, concerns, and thoughts. We'll see you next month on the 4th Wednesday. But just before we sign off, as you know, we are coming up with our annual New York Endovascular Summit, which is scheduled from September 12th to the 14th here in New York City. Great weather, great faculty, great topics, a great environment to discuss the endovascular field, including what we do regularly on a daily basis, the complexity, and the latest future coming in. So you can go to our website, nybevs.org, register right there. You can get all the latest agenda, the fellows courses, the day 1, day 2. We have live cases all the way from Germany, from Dr. Metzger's clinic, from Michigan, and of course from here in New York City. So do join us, and we love to see you here in New York. Till then, have a great day, week, and a month. Thank you for joining us.